Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Anulika Nwakaeze, a PGY3 anesthesia resident at the University of Saskatchewan in Saskatoon, discusses evidence surrounding the use of videolaryngoscopy in adult intubations as an alternative to traditional direct laryngoscopy. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So thank you everyone for joining me this morning for my Grand Rounds presentation. My name is Anulika Nwakaeze. I'm a PGY3 anesthesiology resident at the University of Saskatchewan. And I will be presenting today on considering a future of universal videolaryngoscopy in adult intubations. This is a somewhat incendiary title, but I'm hoping that we can generate a lot of discussion and consider what a future of universal videolaryngoscopy might mean for our profession. I would first like to begin with a land acknowledgement. I want to acknowledge that in Saskatchewan, we are on treaty land. These treaties serve to govern our relationships with Indigenous people. We have come here together today on Treaty 6 territory, which is the traditional territory of the Cree, Saulteaux, Stoney, Nakota, and Dakota peoples. We also acknowledge the traditional homeland of the Métis and honor their contributions. I have no disclosures to share. The objectives for today's meeting are to explore evidence-based recommendations in support of universal videolaryngoscopy in adult intubations, and to outline emerging changes in practice in the use of video versus direct laryngoscopy. I would also like to discuss future directions in airway management and implications for resource allocation and patient care. And the agenda is as follows. One, I would like to touch on the background and significance of this topic, as well as briefly highlight the history of laryngoscopy. I would then like to go into the emerging evidence in support of universal videolaryngoscopy and touch on the guidelines as well. I would then like to discuss potential implications for clinical practice, as well as possible pitfalls in the adoption of universal videolaryngoscopy, ending with a summary and what I'm hoping is a lively discussion. Pictured on the right-hand side is a photograph of intubation using a laryngoscope from the 1920s in the possession of a Dr. David Wilkinson of London. Beginning with a background, as we know, tracheal intubation is a common procedure performed during general anesthesia and as an emergency procedure in the pre-hospital emergency department and ICU settings. Airway management is one of the core skills of the anesthesiologist, be it bag mask ventilation, placement of supraglottic airway devices, intubation either via direct or videolaryngoscopy, and fiber optic intubation. This also includes the use of various airway adjuncts, including bougies or stylets, and anesthesiologists are trained to perform emergency procedures such as cricothyroidotomy and tracheostomy when the situation arises. The standard Macintosh direct laryngoscopy, which requires a direct line of sight to align the airway axes, remains the airway management device used first by anesthesiologists and is classically used to facilitate intubation. Videolaryngoscopy is more often used as a second intention device or rescue therapy in cases of difficult tracheal intubation or anticipated difficult intubation. Delayed, difficult, or failed tracheal intubation is associated with patient harm and death. The American Society of Anesthesiologists practice guidelines for management of the difficult airway defined a difficult airway as a clinical situation in which anticipated or unanticipated difficulty or failure is experienced by a physician trained in anesthesia care. Failed or difficult intubation may result in catastrophic complications, including hypoxemia, pulmonary aspiration, cardiac arrest, and even death. I'd like to touch upon the brief history of laryngoscopy, as I find medical history to be quite interesting, and it can inform, or at the very least, provide a context for our modern practices today. Elective intubation was only possible from the late 19th century onwards, and prior to this time, it was only tracheostomy that was available for patients in respiratory distress. And interestingly, the laryngoscope was initially a tool developed solely for the use of the otolaryngologist or our ENT colleagues. And it was only advances in anesthesia in the early 20th century that made the laryngoscope an essential skill for anesthesiologists. In 1829, A. Babington of London was the first to present a glottoscope, which was a speculum used to displace the tongue and a system of mirrors to visualize the larynx using sunlight for illumination. It was the first device of its kind to use retraction of pharyngeal and supraglottic tissues to obtain a better view of the laryngeal inlet. The term laryngoscope was coined by a friend of Babington's, a Dr. Thomas Hodgkin of Hodgkin's lymphoma. In 1881, Garcia II was the first individual to view the functioning glottis in its entirety and also the first to evaluate the physiology of the larynx. He described the action of the vocal cords during inspiration and vocalization and production of sound in the larynx. Moving on to the early 20th century, we have Jackson and Boyce from Philadelphia, who were the first to describe the combination of direct visualization of the larynx with endotracheal intubation. They were also the first to design a laryngoscope blade with a distal light source, as opposed to using sunlight or ambient light for illumination, as well as a lateral approach through the oral cavity and the oropharynx. In fact, the development of today's laryngoscopes and the lateral approach we use for direct laryngoscopy were dependent on Jackson's introduction of distal illumination. And the credit for many laryngoscopy techniques that we use today can be attributed to Jackson and Boyce. And pictured, we see Jackson performing laryngoscopy with Boyce as his assistant holding up the neck, and this position they felt was essential to successful laryngoscopy. In 1913, Janeway was the first anesthetist to publish on direct laryngoscopy and also the first to design a battery-powered laryngoscope. All publications on direct laryngoscopy prior to this time were actually done so by surgeons. We then move on to some of the big names in anesthesia and airway management, being McGill, Miller, and McIntosh, whose eponymous tools we still use today. Endotracheal anesthesia became increasingly prevalent after World War I. McGill realized that reconstructive facial surgery performed on disfigured soldiers was easier and more successful under general anesthesia with the airways secured by an endotracheal tube. In 1926, he designed the McGill forceps, which were used to place an intratracheal catheter during insufflation anesthesia. In 1941, Miller described the straight laryngoscope, the Miller blade, which was designed to directly lift the epiglottis and is still favored in pediatric anesthesiology today. We then have McIntosh, who designed the curved McIntosh blade in 1943. McIntosh believed that the hallmark of a successful anesthetist was the ability to pass an endotracheal tube under direct vision. Prior to 1943, poor straight blade techniques hindered the development of laryngoscopy, with the majority of anesthetists struggling to expose the vocal cords of an unparalyzed patient. At the time, the most popular method of direct laryngoscopy involved the midline approach, passing a straight blade laryngoscope beyond the epiglottis to evert it. McIntosh was the first to suggest routinely placing the blade's tip in the vallecula to indirectly lift the epiglottis. And pictured below from left to right, we have McGill, Miller, and McIntosh. We then move on to advancements in indirect laryngoscopy. It's interesting to note that laryngoscopy remained essentially unchanged from the mid-20th century until the introduction of the flexible fiber optic scope in the 1950s, followed by the rigid fiber optic in the 1990s. Videolaryngoscopy was introduced in the 2000s with numerous models now available. And a fun fact, it was a Canadian surgeon, a Dr. John Pacey, who was the first to introduce the videolaryngoscope in 2001. The development of a variety of indirect video-assisted laryngoscopes, or videolaryngoscopes for short, has brought us back to a modern era of indirect laryngoscopy. This table is a non-exhaustive list of available videolaryngoscopes in today's market. These differ in the level of evidence supporting their use, as well as the method of insertion and display. Overall, videolaryngoscopes can be divided into channeled versus non-channeled categories, with the non-channeled being further subdivided into angulated versus non-angulated. You may be able to spot some familiar names in this list, namely the CMAC and the CMAC-D blade, which we have available at our institution, as well as the glidoscope. In terms of advantages and disadvantages, there are a few that we can discuss in using videolaryngoscopy. I'll bring your attention firstly to the advantages. Videolaryngoscopy confers precise visual control when managing a patient's airway. It allows for confirmation of endotracheal intubation via visualization of a screen. It allows for shorter intubation time for patients with both normal and difficult airway, and greater success rates of intubation for those who do present with difficult airway features. Videolaryngoscopy can be a great teaching tool. One can record anatomy and provide real-time coaching, particularly for trainees in managing airways, and can be used as a diagnostic tool as well. For example, videolaryngoscopy, as well as nasopharyngoscopy, under local anesthesia can add useful information about a patient with a known or suspected glottic or supraglottic pathology. It can also allow for easier placement of oral gastric and nasogastric tubes, which is something that I have found particularly useful when placing these tubes, and also confers better posture for intubation. Those that are based on the McIntosh blade, so for example, the CMAC, can allow for two views of the glottic inlet, so essentially allowing for both a direct and an indirect view. So if one view is obstructed by, say, secretions or soilage of the airway, the intubator still has another option, and this can be very valuable for teaching as well. On the other side, some disadvantages in videolaryngoscopy is that there is not necessarily a correlation between the laryngeal view and predictors of intubation difficulty. Of course, I'm sure we've all encountered this at one point or the other when our lens becomes obscured or fogged, which can pose challenges for airway capture. It does necessitate good hand-eye coordination, which is a skill that I developed early on in residency as I had some challenges at first with maintaining this hand-eye coordination. But after receiving some helpful coaching from my staff people, this was a skill that I was able to develop. Of course, videolaryngoscopy can be quite expensive, which is a hindrance to its universal adoption, which we will touch on later. Some of these devices have been associated with increased morbidity due to decreased space between the blade and the palate-pharyngeal wall. The intubator might become so focused on viewing the screen instead of directly evaluating where the endotracheal tube is being positioned. Of course, there can be equipment malfunction, such as microchips, screens, and cables becoming easily damaged. And the view does become restricted from a three-dimensional to a somewhat two-dimensional view. And some of these devices lack pediatric blades. So having now reviewed a background and historical context, as well as recent advances in laryngoscopy, I would now like to delve into further some of the emerging evidence in the literature in support of videolaryngoscopy. There is a mounting evidence base to suggest the improved safety and efficacy profile of videolaryngoscopy as compared to direct laryngoscopy across all designs, populations, users, and settings. Videolaryngoscopes are being used with increasing frequency in adults undergoing tracheal intubation. I would like to draw your attention to this Cochrane Systematic Review and Meta-Analysis update. It suggests that there are higher rates of single first attempts at intubation with all videolaryngoscopy designs as compared to direct laryngoscopy. In particular, the hyperangulated blades have been demonstrated to show lower rates of esophageal intubation and patient-reported sore throat. The max style and channeled blades have also been associated with lower rates of complications such as hypoxemia. In essence, the bottom line from this systematic review and meta-analysis update is that videolaryngoscopy is associated with lower rates of failure, esophageal intubation, and hypoxemia, with increased rates of first attempt success, thereby suggesting a highly favorable safety profile of VL for adults undergoing tracheal intubation. I would next like to present a pre- and post-intervention observational study that was done by our anesthesia colleagues in France using videolaryngoscopy as a first intention technique for tracheal intubation in unselected surgical patients. This was a quality improvement project performed in over 26,000 adult tracheal intubation procedures over a 3-year period from 2017 to 2020. It compared the use of videolaryngoscopy versus direct laryngoscopy in what they termed compliant versus non-compliant hospitals. These were 2 hospitals that were staffed by different sets of anesthesiologists, and both underwent a pre-intervention, an implementation, and a post-intervention period. In the pre-intervention period, a standard MAC-DL was available and routinely used as the first intention device for intubation in all operating rooms. A videolaryngoscope, namely a glidoscope, was available and routinely used, but as a second intention device and only in cases of difficult intubation. It's important to note that in this study, the operators had little to no experience with videolaryngoscopes, and there was a training period provided to those in the compliant hospital. In the implementation period, a videolaryngoscope was made available in each operating room at both hospitals. In the compliant hospital, two facilitators who were practicing anesthesiologists strongly advised the operators to perform at least half of their tracheal intubations using a videolaryngoscope. And each day, the entire team was trained on the use of VIA, first using mannequins during a 2-week period before the trial, and then on live patients during the implementation period. These anesthesiology facilitators were present daily to explain good practices when using the videolaryngoscope. And the advantages of videolaryngoscopy were highlighted and reinforced, namely improvement of glottic views, intubation under visual control, reduced hemodynamic sequelae, ease in cases of cervical trauma, as well as in patients with morbid obesity, and decreased occurrence of esophageal intubation and of difficult intubation. And in the post-intervention period, videolaryngoscope was again strongly recommended to be used as the first intention device in the compliant hospital. In contrast, in the non-compliant hospital, there was no specific teaching or incentive to use the videolaryngoscope. Rather, the choice of intubation device was left at the discretion of the operator. In this way, the non-compliant hospital was used as a control group as no specific training was provided other than the device being available. What we saw is that throughout the course of the trial, in the compliant hospital, the use of videolaryngoscopy increased from 0.27 to 66%, with concurrent decrease in the use of direct laryngoscopy from 93 to 33%. On the other hand, in the non-compliant hospital, where there was no specific teaching or incentivization, direct laryngoscopy remained the first intention device most used both pre and post-intervention. The implementation of a videolaryngoscopy as the first intention device for all tracheal intubation procedures was associated with an increase in the proportion of easy airway and tracheal intubation, as well as less frequent need to resort to a rescue technique such as use of a stylet or a bougie, and was also associated with an improvement in glottic views and reduced operator-reported difficulty of intubation. And as a point of clarification, an easy airway or an easy tracheal intubation was in essence defined as the opposite of a difficult airway. So these being a Cormack-Lehane grades of 1 or 2, the absence of difficult mask ventilation, and the absence of the need to resort to a rescue technique for intubation. Here I have the charts demonstrating the use of the Macintosh videolaryngoscope or the glidoscope as the first attempt intubation technique in the compliant hospital. We see in the pre-intervention period, the rates of using the videolaryngoscope were quite low, with rates increasing in the implementation period following the quality improvement project. And we see in the post-intervention period that the rates continue to rise, although they were still quite modest. But by the time we approach 2020, and at the onset of the COVID pandemic, we see a peak in videolaryngoscope use to 95%, leveling off to about 90%. In contrast to the non-compliant hospital, the rates of videolaryngoscope use remained quite low throughout the pre-intervention and implementation and post-intervention periods. However, we do see a spike of use to a peak of 35%, also associated with the COVID-19 pandemic. All of this to say that what I glean from this is that dedicated training, as well as incentivization and support for operators, appears to be crucial in changing perceptions and gaining buy-in for the use of universal videolaryngoscopy. I'd also like to bring your attention to this study, which is actually what started my interest in looking into universal videolaryngoscopy. And it's a paper that I discussed further at my journal club presentation. This was a group from the UK who undertook a structured approach to conversion to videolaryngoscopy for all intubations in their anesthetic and ICU departments. The study determined the feasibility of conversion from direct to videolaryngoscopy. They undertook a formal and prolonged trial of mandatory videolaryngoscopy, preceded by logistics planning, provisional capacity assessment and cost analysis, and culminating in a presentation of a business case to support implementation of change. So after departmental training, the authors undertook a 2-month trial period of mandating videolaryngoscopy for all adult in-theater intubations. And thereafter, VL remained widely available but not mandated. Anesthesia providers, including staff anesthesiologists, trainees, and anesthesia assistants, were regularly surveyed throughout the study period to evaluate departmental opinion regarding the introduction of universal videolaryngoscopy. Before the trial period, approximately 1/3 of anesthetists judged that universal VL would be of benefit overall to patient safety, team dynamics, and quality of care. Drawing your attention to the charts, we have the blue column, which represents those who had full unreserved support for adoption of universal videolaryngoscopy. The orange column represents respondents who expressed reservations, particularly from both junior and senior anesthetists, which focused on training concerns. And in the green column, we have those who did not support this change to universal videolaryngoscopy. We see that by the end of the trial period, support for a changeover to videolaryngoscopy increased. And 6 months after this trial period, the support had grown further and was almost unanimous. Anesthetists reported significant benefits in clinical performance, in teaching, in human factors, especially teamwork and situational awareness. I found it to be quite interesting that before the trials, it was actually the trainees who were the most staunch, who were most staunchly against the adoption of universal videolaryngoscopy. And they cited concerns with their training, particularly moving from one center to another, where videolaryngoscopy would be less available, and attrition in their skills of direct laryngoscopy. And however, as the trial went on, it became evident that there were many benefits to using videolaryngoscopy in training. And trainees found that they were better able to receive coaching and feedback from their staff persons as they were managing airways. They were granted more attempts to manage difficult airways and were also provided with more opportunities to attempt these difficult intubations than they otherwise would have when using direct laryngoscopy. At this center, the CMAC was chosen as their videolaryngoscope of choice, as it is similar to the conventional Macintosh direct laryngoscope, with the availability of the extra-curved or hyperangulated D blade, which can be used for difficult procedures, as well as the inclusion of a separate screen from the laryngoscope blade, allowing a more experienced provider to be able to give feedback on what the trainee is doing. At the time, this was the first report of conversion to universal videolaryngoscopy as a routine first choice option in anesthetic and ICU departments in the UK. This was in 2017. Having explored some of the emerging evidence, I would also like to touch upon guideline recommendations, focusing on the Canadian Airway Focus Group, who published recommendations in 2021, now recommending the use of videolaryngoscopy in appropriately selected with the appropriately selected blade type to facilitate all tracheal intubations in all adults. There is also support from other groups, such as the American Society of Anesthesiologists, which published strong recommendation for the use of videolaryngoscopy in 2022, and the UK Difficult Airway Society in 2015 recommended availability and skill in the use of videolaryngoscopy for airway practitioners, with recommendations in 2018 to consider videolaryngoscopy for the intubation of critically ill patients. Interesting to note that these 2018 guidelines preceded the COVID pandemic by about 1 to 2 years. And the pandemic really did modify intubation practices in operating rooms, particularly in ICUs and emergency departments, with videolaryngoscopes being more widely used to limit the risk of contamination to operators. And so, what are the potential implications for practice? It's my hope that at this point in the presentation that some of you have generated some discussion points that we can explore further in the question and answer period, particularly what some of the implications might be for us in considering a future universal videolaryngoscopy. There is increasing interest in and numerous publications describing the benefits of videolaryngoscopy, but its role, or I should say its universal role in clinical practice, remains contested. We know the VL is now a core component of modern airway management, and airway managers should be skilled at videolaryngoscopy, including the use of a hyperangulated blade, which has been demonstrated to decrease the rates of esophageal intubation, patient-reported sore throat, and be of use in both anticipated and unanticipated difficult airways. However, in order to achieve these goals, there needs to be universal availability of videolaryngoscopes as well as proper training in their use. Although some hospitals and anesthetic departments have adopted universal VLs for intubations, despite the evidence and guidelines, few centers worldwide have claimed to do so. And we know that universal adoption, it is highly likely, according to the evidence, that universal adoption of videolaryngoscopy has the potential to enhance patient safety, improve success rates, and facilitate learning, making it a valuable practice in clinical settings. But what might be some of the potential pitfalls of doing so? And I confess, as I was preparing for this presentation, I didn't find much in terms of authors discussing the negative implications or potential pitfalls of universal adoption of VL. I will say that data are lacking regarding the clinical consequences of VL as a first intention device. And there have been few studies that have examined predictors of difficult tracheal intubation using videolaryngoscopy. I'm hoping this is something that perhaps we can explore further in our question and answer period. In terms of challenges to overcome, decontamination will certainly be amongst them. In the previous study that was done in the UK that employed the structured approach for conversion to universal videolaryngoscopy, it chiefly fell on the anesthesia assistants to provide decontamination for these videolaryngoscopes. Interestingly to note that in their center, the AAs actually reported an increase in their participation in airway management, and overall were on board with taking on this role of decontamination processes. However, that may not necessarily translate to every center. Availability of these videolaryngoscopes will certainly be a challenge to overcome, as well as tracking their whereabouts if they become universally available in operating rooms and ICUs and emergency departments. It poses a question of how are we to track these devices and ensure that they are functioning properly so as not to pose any threats to patient harm should one want to use the devices and find that they are not functioning. And of course, the cost analysis would likely be one of the biggest drawbacks in the adoption of universal videolaryngoscopy. I would now like to present a summary of the main points as discussed today. Starting from the historical roots of laryngoscopy, which was first developed as an essential tool to facilitate tracheal intubation, with many designs and techniques developed in the 19th and 20th centuries still being used today. Recent advancements in technology have ushered in the videolaryngoscopy era of airway management and have brought us to a modern way of indirect laryngoscopy. VL has been demonstrated to have a favorable safety profile in comparison to direct laryngoscopy, with improvement in glottic views, higher rates of first pass success, and increased proportions of easy intubations. Guideline recommendations support the use of videolaryngoscopy, with the Canadian Airway Focus Group supporting the adoption of universal videolaryngoscopy. Some institutions worldwide have become early adopters of this, but these numbers still remain low. And further research is needed to assess the feasibility of implementation as well as stakeholder involvement needed to assess the feasibility of adoption to universal videolaryngoscopy. I have my select references highlighted here and have also included a QR code that you can scan to better access these articles if you would like to read into them further.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.